Good evening, everyone, and welcome to this special webinar on bioregeneration. I'm Mukta Sandhu, Senior Scientific Education Manager at Geistlich Pharma, Switzerland. I'm extremely happy to announce that today's speaker is a young clinician who's passionate about his research. Dr. David Palombo is a specialist in periodontology and implantology with his profound interest for the use of microsurgical techniques in the treatment of periodontal disease and peri-implant disease. He's an avid lecturer in the national as well as international congresses. And with his charm, he has a knack of engaging the audience, and that's what we will be experiencing today. He will be speaking on the concept of bioregeneration around teeth and implants. So, Dr. David Palombo, thank you very much for your time, and the stage is all yours.
So, hello everyone. It is a great pleasure for me to be here today and share with you sometimes talking about the bioregeneration approach around natural teeth and dental implants. This is the outline of the presentation that we're going to follow. First of all, we're going to discuss the modern indications for tissue regeneration. We're going to then go through the concept of bioregeneration. We're going to discuss the layers approach, which is the clinical technique that I'm adopting nowadays to apply the bioregeneration concepts. And of course, I'm going to share with you the very first lessons that I've learned in the field. So first of all, let's discuss the indications for regeneration. And if we talk in any scientific context about what is the purpose of dentistry, implant dentistry, restorative dentistry, and any therapeutic intervention that we provide at the rehabilitative level, we fundamentally all agree that the objective of our work is mimic nature. And mimicking nature means reestablishing the status quo ante a specific disease, which can be, of course, the loss of a natural tooth or the loss of a given tissue or structure. And of course, specifically when we talk about implant-supported prosthodontics, reestablishing and mimicking nature means following a very detailed series of clinical requirements, wide aesthetic scores, pinch aesthetic scores. And of course, this is related also with the provision of a peri-implant anatomy, which is characterized by an adequate amount of hard tissues and an adequate amount and quality of the peri-implant soft tissues. All of this, it's intended to create a conducive environment for the long-term maintenance of peri-implant health, which is of course identified by the absence of peri-implant signs of inflammation, by the absence of marginal bone remodeling over time, and by an overall stability of the peri-implant tissues. However, this is what I see every day in my clinical activity. I see malpositioned implants which have been placed without any consideration with regards to the prosthetic treatment plan. And I see prosthetic rehabilitation on top of these implants, which in any way attempted to correct the mistakes performed by the surgeon. On top of that, of course, I see prosthetic rehabilitations, both on natural teeth and implants, which put the patient in the worst condition ever to maintain optimal plaque control around our manufacturers, which put the patient in the worst condition ever to maintain long-term periodontal and peri-implant health. And when we fail to do what is supposed to be our job, which is saving natural teeth, and we fail to elaborate a specific strategy to reestablish a functional dentition through the use of dental implants, the end point of this process can only be one. So it is very clear in my mind that without a plan, the only possible thing that we can do is planning to fail. And thankfully, today we have a plan. The plan is called periodontal treatment sequence. And the plan established that we have to perform a proper diagnosis and prognosis of the teeth in our periodontal affected patients, that we have to reestablish health through a stepwise treatment sequence, which is intended to treat the disease and to restore health in our patient's mouth. And once we have restored health, we have to create a tailor-made program called Supportive Periodontal Care Program, which is intended to maintain on the long term the health that we have achieved through the active phase of treatment. And in the very end, once we have diagnosed our patients, once we have established the prognosis of every single tooth, once we have treated the tooth or periodontal diseases and conditions, and once we have created a conducive environment for the maintenance of long-term health around our therapeutic interventions, then it's the time to restore function and aesthetics through an interdisciplinary treatment sequence. And of course, the second that we move from a therapeutic intervention to a rehabilitative intervention, we have to acquire a prosthetically guided mindset, which means that every time that we are rehabilitating a patient with a treatment sequence that is going to end with a prosthetic device, the objective should be the prosthetic rehabilitation. So, for example, when we are planning an implant placement, we should start with the prosthetic treatment plan, which can be either a digital mock-up or a conventional mock-up, which nowadays can be easily digitalized. And we have to go backwards in our treatment sequence with only one question in mind. And the question is very easy. Do I have enough bone to place the implant platform in the optimal prosthetically guided position? And of course, if the answer is yes, the case probably eats a piece of cake and it's going to be very easy to rehabilitate our patient. But as it happens many times in life, the answer is going to be no. It's going to be that we do not have enough bone for placing the implant in the optimal prosthetically guided position. And of course, the following answer that we have to answer is, are you willing to accept any compromise or not? And when we go back to the treatment sequence of our patient, I think it's very important for us to identify a very clear demarcation line, because everything that comes before the interdisciplinary treatment phase of our interventions, it's fundamentally disease-based. If the patient has periodontitis, we treat periodontitis. If the patient has cavities, we treat the cavities. But once we start to rehabilitate a patient from a functional and aesthetic standpoint, everything becomes patient-based, and different patients have different requirements. If we take a look at what patients want in an everyday clinical scenario, we see that, for example, in the Scandinavian cohort of patients attending a periodontal specialist practice, 82% of patients consider very important to have healthy teeth, and 77% consider very important to have general well-being, while 74% consider very important to be free of any pain during the treatment. Only 15% of patients consider very important to have better appearance, while only 1% of patients consider to be non-important to have postoperative pain. So you see, we're facing a conundrum here because we have a minority of patients seeking for an improvement in their aesthetic appearance, but a very smaller minority of patients willing to undertake the clinical steps that are required to achieve such results. So in an attempt to simplify something that is very complicated, I typically try to categorize patients into different groups. From one side, which is approximately 10 to 15 to 20% of the patients that you're going to treat, we have performance seekers, which are the patients willing to do everything to achieve the result. It doesn't matter if the treatment sequence is complex. It doesn't matter if it requires multiple steps. They are looking for the end result. But a vast majority of patients, unfortunately, are not looking for a very specific end result. They're willing to do the minimal amount of effort to solve their problem and to step outside of the dental office as soon as possible. And unfortunately, in my mind, the most dangerous category of patient is the second one, is the one that is not looking for an invasive treatment. Because when we try to accommodate the requirements of patients seeking for simplifications in the treatment sequence, many times we can fall into a very, very complex mistake, which is, for example, the adaptation of the implant position in a non-prosthetically guided site. And this very nice case cohort study that we performed at the University Complutense shows that when we try to adapt the implant position to residual bone availability by tilting the axis of the implant toward the buccal axis, we increase the risk of having peri-implant soft tissue deficiencies by 34 times, which has a huge impact on the final result that the patient is going to see. So, of course, here we are starting to discuss something that is more philosophical than clinical, because we could argue about how much compromise is too much compromise. Maybe if we were about to discuss that one of these patients is 92 years old, we could say that maybe this compromise or some of these compromises are good enough for that patient. But who decides? Do we decide? The patient decides? It's a hard question to answer. What I can tell you, based on clinical experience, is that when we are facing this conundrum in the aesthetic zone, in the vast majority of cases, patients did not understand what accepting a compromise meant when they chose a simplification of the treatment plan. This beautiful 30 years old lady did not understand that accepting a compromise in implant placement and the subsequent prosthetic rehabilitation that follows without the performance of a vertical bone augmentation, which was exactly the treatment plan that was indicated, meant such a huge compromise, because this treatment in the end lead only to a final result. And the final result, of course, is the removal of the previous implant, the delivery of a novel vertical bone augmentation, which is even more invasive than the one that should have been performed at the beginning of the treatment plan, the reconstruction of a bone architecture that is consistent with the prosthetic treatment plan, and the delivery of a new implant rehabilitation. So there are cases in which, even if we like to simplify the treatment sequence, even if we like to be minimally invasive, we have to regenerate. And it's not just about aesthetics, because we have some cases which have nothing to do with aesthetics, but require inevitably a regenerative intervention to allow the delivery of an implant-supported rehabilitation that is cleansable and that is maintainable over time. So even in these cases, where sometimes we have to combine both a vertical bone augmentation procedure with a periodontal regenerative intervention, even in patients which are not seeking for an aesthetically optimal result, sometimes regeneration is not avoidable. And of course, regeneration is the only therapeutic intervention that allows us to place the implant in the optimally prosthetically guided position, surrounded 360 degrees by an adequate amount of viable bone. But of course, these interventions are not easy. These interventions require a very high level of technical skill and expose ourselves and the patient to the risk of very morbid complications. So it is very important to understand that patient selection, of course, is the most influential factor, along with proper clinical training, and that the variability of this intervention can be very, very high in terms of complications. Some authors report a very, very minor amount of complications, while others report a very high number of complications. So we have tried in some papers that we have performed in the last years to unveil which are the technical elements which can guide the clinical practitioner to a successful vertical and horizontal bone augmentation procedure in clinical practice. But nonetheless, even if an attempt has been provided to achieve minimal invasiveness, nowadays we know that these still are high technically demanding and morbid interventions that require a specific amount of skill and very good capacity to perform case selection in order to be delivered. So in this context, how does the concept of bioregeneration was born? Well, basically, bioregeneration is simply an attempt to simplify and optimize the regenerative process. What is regeneration in the end? Regeneration is the reestablishment of the status quo ante, the loss of a given tissue, which was lost due to an injury or to a disease. And of course, when we talk about regeneration, two very common models, healing models that we can identify in the oral cavities are the periodontal regeneration model and the fresh extraction socket. Both of these models involve tissues with an ectomesenchymal origin. Both of these models are characterized by the formation of a blood clot inside the defect, the conversion of the blood clot into a provisional matrix, which is a granulation tissue, and the differentiation of the granulation tissue into an immature, undifferentiated tissue, as for example, the woven bone, which of course then differentiates and gets and matures into lamellar bone. So we can see that in both healing models, we have the same sequential series of biological events, Yet we achieve two completely different results. Because on one side, we achieve periodontal regeneration, which means, of course, the formation of new cementum, new alveolar bone proper, and new functionally inserted fibers in between, which is the periodontal ligament. While on the other hand, we just achieve an intramembranous ossification, which is, of course, the bone formation inside the extraction socket. And of course, you know very well where the difference resides. The difference is represented by the different cellular activity. Cellular activity is the one responsible for the conversion of the granulation tissue into a differentiated immature tissue. Regeneration is just about creating the proper context for cellular activity to occur. Regeneration is just about creating the proper context for the right cells to be in the right place at the right time. So what we do as clinicians is to put at the core of the regenerative process the cellular activity and to provide the cellular activity with an optimized environment to facilitate the occurrence of the regenerative process. And of course, an optimized environment means, first of all, to provide adequate vascular supply through the creation of optimally designed gingival flaps. Of course, it means to create a very mechanically stable and secluded space through the use of a space maintenance technology, which can be, of course, either particulated bone or very different elaboration of bone blocks harvesting. And finally, and this is probably the most influential factor, creating the optimal environment means protecting the regenerative site with a watertight, first intention, absolutely passive wound closure, which allow us to completely isolate the regenerative environment from the microbiological and mechanical interferences which are present in the intraoral environment. So irrespective of the type of regenerative intervention that we're performing, this can be the management of a fresh extraction socket, an intrabony defect around the natural teeth, an open sinus lift elevation of vertical bone augmentation. The game of regeneration is always the same. And the game of regeneration is based on cellular activity at the center of the process, which is surrounded by a number of concomitant factors. And it is in this context that the bioregeneration approach has its foundations. Bioregeneration simply means creating an optimized environment for cellular activity to work at its best in the regenerative environment. And this is an approach that is based on the introduction of a novel technology called RegenFast, which is a viscoelastic gel provided in an injectable format, which can directly be applied to the defect site with an open flap approach, and which is composed of polynucleotides, hyaluronic acid, and mannitol. Specifically, polynucleotides are DNA fragments obtained from male gonads of salmon trouts, which have the capacity to bind water, creating a natural cross-linked gel, and at the same time have multiple healing supportive capacities. On the other hand, of course, we have hyaluronic acid, which is a very well-known molecule with very potent healing stimulation activities. And the combination of these two elements is stabilized by the use of an antioxidant, which is mannitol. Specifically, if we take a look into the biological activities of polynucleotides, we can identify three fundamental mechanisms by which these molecules can promote the healing process, both at the extracellular and at the intracellular environment. First of all, as a macromolecule itself at the extracellular environment, polynucleotides, by binding water through a natural cross-linking process, they can act as scavengers for free radicals, protecting replicating cells from free radicals. At the same time, at the metabolites level, so once polynucleotides are catabolized into nucleosides and nucleotides, we can identify two fundamental mechanisms. At the extracellular environment, we have the inflammation modulation pathway by which nucleosides and nucleotides communicate with the surrounding cells, providing information regarding tissue damage. So we fundamentally stimulate cell replication in the context of a reparative process by upregulating anti-inflammatory interleukins like interleukin-10 and VEGF, and by downregulating pro-inflammatory interleukin like interleukin-6 and TNF-alpha. What is very important to understand is that the cellular stimulation obtained through this inflammation modulation pathway maintains contact inhibition. Cells under the inductive activity of this biological booster maintain a controlled cell replication activity. If we place these cells in a petri dish and we promote their replication with a biological booster such as polynucleotides, cells replicate up to creating a monolayer and then they stop replicating. This is exactly the opposite of what it happens when we apply a growth factor. A true growth factor induces an uncontrolled cellular replication as long as the growth factor is available, exactly as it happens with a tumor. When we move at the intracellular environment, and this is the third biological mechanism of polynucleotides, we can identify a very interesting pathway, which is called the salvage pathway or the building block theory. Fundamentally, nucleotides obtained by the catabolism at the extracellular level of polynucleotides into nucleosides and then nucleotides. Once nucleotides enter the intracellular environment, they can act as ready-to-use genetic material for DNA polymerases to perform the replication of the genetic material. So all of a sudden, the DNA polymerases of the replicating cells has an increased availability of genetic material to perform the cellular replication. Of course, we have some preclinical evidence supporting the effectiveness of this technology. For example, when we perform an incision in the dorsal skin of a mice model, we can identify that the use of polynucleotides as compared with a negative control or with the use of hyaluronic acids, improve the deposition of collagen fibers, both in a qualitative way and in a structural organization standpoint, where we see that the collagen fibers under the inductive effect of polynucleotides are more well organized and more robust. What is more interesting to see is the combination of polynucleotides and hyaluronic acids together. When we look at human primary fibroblast of gingival origin, when we look at colonies of primary gingival fibroblasts, we see that the combination of polynucleotides and hyaluronic acids as compared to polynucleotides alone or as compared to a negative control, provide a synergistic effect once again in the replication of the collagen fibers and in the structural organization of those. At the same time, we have emerging clinical evidence supporting the effectiveness of this technology. First of all, we have a very interesting randomized controlled clinical trial by Professor Pilloni from the University of Rome, showing that when we apply this gel in a non-surgical environment, so in an open pocket, the effectiveness is not there. Fundamentally, we do not see statistically significant changes in terms of pocket reduction, most probably because the gel itself is disgorged out of the pocket in absence of primary intention wound closure. Where we see an interesting effect is in a closed environment, both in bone augmentation procedure and in periodontal regeneration model. Both the reports from Professor Mario Beretta and from Professor Francesco Cairo show promising results in terms of new bone formation in bone augmentation procedure with very promising findings in terms of graft revascularization. And at the same time, in periodontal regeneration model, we have promising results when we apply a mixture of polynucleotides and hyaluronic acid in reconstructive intervention around teeth affected by intrabony defects. So if we want to make a small summary about the properties of this product, we can see that for the actual knowledge, this is a safe product, no adverse reactions have been described, which promotes the growth of fibroblasts and angiogenesis based on preclinical evidence, which promotes intercellular exchanges, creating a favorable environment for cellular replication, and which has promising histomorphometric findings at surgical reentry, combined with promising finding in the reconstruction of intrabony defects. So basically, when we go back to the key factors of a regenerative environment, these are the two elements on which this technology works: cellular activity itself and the promotion of vascular supply. So, which are the first clinical impression after the adoption of this technology? If I have to report you my personal experience in the last 3 years of implementation of this technology, I've been performing approximately 58 cases composed of 22 cases of bone augmentation procedures, 18 cases of periodontal regeneration, and 16 cases of soft tissue augmentation, which are divided both in two-stage GBR, one-stage GBR, peri-implantitis defects, and periodontal regeneration. I have to say that I haven't found any adverse reaction nor side effect after the use of this technology. And of course, I had some surgical complications, specifically two periodontal defect underwent adhesions of the surgical wound, and one gingival recession coverage surgery underwent a failure. When we take a look at the guided bone regeneration cases, these are composed of a 30% of combined vertical and horizontal defects and a 70% of horizontal defects, 60% of which derive from peri-implantitis. So now, of course, we have to ask ourselves, how should we use this novel technology? And this is a discussion that we had for a very long time with the very first clinicians that were involved in the testing of this new material. And you can see a very nice video from my friend Federico Rivara, who has been involved with me since the very beginning in testing this product. And this is an application that you're going to see from many clinicians, where fundamentally RegenFast is mixed with Bio-Oss outside of the patient mouth in order to create a combined product that can be easily transferred into the patient mouth and directly into the defect of the patient. This, of course, it's an attempt to take advantage of the mechanical properties of hyaluronic acid. But let me say that in my mind, it's an approach that has no respect whatsoever for the biological properties of the product, because we have stated that this product targets living cells and promotes increased vascular supply. And I'm sure we can agree on the fact that there are no living cells inside our Bio-Oss or inside any bone replacement graft that you're using outside of autogenous bone. On top of that, this specific strategy, in my mind, sacrifices a little bit the space maintenance capacity of our system. If you are like me and you are a huge fan of the sausage technique, at the end of your regenerative intervention, right before applying the sutures, you want to see absolute primary stability of your material with a very nice tension in the membrane. And once you press with your finger or with your periodontal probe on top of your regeneration, you don't want to see any movement whatsoever. Well, if you combine RegenFast with Bio-Oss outside of the patient mouth, especially if you exceed in the quantity of RegenFast, you're going to see that it's almost impossible to achieve such primary stability, because the material itself, it's going to allow Bio-Oss to disgorge outside of the regenerative side. And this is the basis upon which I developed what I called the layers approach, which is fundamentally a regenerative strategy that tries to optimize and take advantage as much as possible of the biological activity of this product. So if we try to simulate a very common regenerative environment, like the placement of an implant with a guided bone augmentation procedure, once we raise our flap and we place our implant, the very first application of the product is going to be delivered on top of the receiving bone, which of course is full of living and viable cells. The second layer is going to be applied on top of the membrane, which is going to get in contact with the periosteum at the end of the surgery. And a third layer, if it's available, is going to be placed on top of the suturing line in order to promote soft tissue healing on top of the regeneration side. So you see the very first application in a very small amount is painted on top of the receiving bone in order to target the viable cell in the receiving side. Bio-Oss is applied without being mixed with RegenFast. It's simply slightly hydrated with saline, as we usually do. This doesn't impair in any way the primary stability of the system. And once the membrane is perfectly stabilized to achieve primary stability of the material, we apply our second layer on top of the membrane, which of course does not target the membrane itself. The membrane is simply a vehicle to apply region fast in contact with the periosteum of the closing flap. And finally, if we have some additional material available, we can apply the product on top of the suturing line in order to promote soft tissue healing at very early stages of the postoperative period. So let's see some of the cases that I treated in order to have a better understanding of the potentialities of this approach. And this is the very first case where I applied this technology. It was a very challenging case for me. It was the very first case that I had to treat after my residency at the University Complutense of Madrid, and I was back in Milan. And as you can see, it's a case of previous implant failure, multiple implant failure, where due to a peri-implantitis at site number 15, the implant was extracted and an oroantral fistula was developed, which was closed with multiple attempts of Rerman flaps, the last one of which was performed with a Bischaffet pad flap. We have still a residual tooth number 14 with a hopeless endoperiodontal lesion. The teeth has already been treated with a apicoectomy, but still has symptoms and a residual pocket. And at the same time, we have a residual peri-implantitis on implant number 17. So you see, it's a challenging scenario. We have a vertical defect. We have dehiscence on the floor of the maxillary sinus. And on top of this, the patient was a smoker of 10 cigarettes a day. So first of all, we put the patient in a smoking cessation program, and we achieved smoking cessation with this specific patient, after which we are ready to deliver the surgery. So you see, we are raising a full thickness flap in a very conventional manner. We identify the dehiscence at the level of the sinus floor. We extract tooth number 14 with the unsalvageable endoperiodontal lesion, and we extract implant number 17. You see, of course, we have a vertical defect, but at the same time, due to the multiple complexities of the patient history, I didn't feel safe in performing a vertical augmentation with a non-resorbable membrane or a bone block. So I chose to perform an open sinus elevation. You see the elevation of the Schneiderian membrane and the tunneling of the Schneiderian membrane up to reaching the dehiscence of the maxillary sinus at the mesial aspect of our regenerative site. We fill the subsinusal space with Bio-Oss. In this specific case, there is no need for the use of region fast inside the sinus because we have a very favorable and contenative environment. And then we are finally ready to apply region fast on top of the receiving site. So you see a very first layer on top of the receiving bone, which is followed by the stabilization of a BioGuide membrane, the placement of pure Bio-Oss without the use of any autogenous bone, and the stabilization of the membrane with multiple titanium pins and with sutures. You see a second layer of region fast is applied in this very first case, both below and on top of the membrane. But in the following cases, as you will see, I stopped applying the product below the membrane. I only applied it on top of the membrane to facilitate the interaction with the periosteum. You see the first intention watertight closure and the application of region fast on top of the suturing line. This is the 2-week sealing. And here you can see the CBCT 6 months down the road, where we see a surprising gain in bone volume, considering the regenerative technology that we adopted, if we compare the postoperative CBCT with the baseline. So we see that now we have reestablished a bone volume that is compatible with the placement of implants in a prosthetically driven position. And we are finally ready to perform the re-entry procedure according to our treatment plan. So you see the re-entry 6 months after the regenerative intervention, where we actually have a very favorable result if we consider that we just adopted a resorbable membrane and no autogenous bone whatsoever. Of course, with the use of a non-resorbable membrane and with the use of autogenous bone, we could have achieved higher amount of vertical bone gain, but probably for this specific case, this was more than enough to allow the placement of implants in a prosthetically guided position and solve our case. You see that we performed some 3 fine sampling, harvesting You see that we perform some harvesting of bone samples with tree finds in order to have some bone histologies, and we placed our implants according to our prosthetic plan. As you can see, sometimes it's hard to perform a very clean cut with the tree fine burr. I created a very small dehiscence with the vibration of the tree fine that was simply compensated with the addition of a very small amount of Bio-Oss on the buccal aspect of the mesial implant. And 4 months afterwards, you see the reopening phase, where we basically have to provide the patient with an apically repositioned flap in order to gain vestibule depth. So this is a very conventional vestibuloplastic technique with a small modification in which we create a very small pouch at the mesial aspect of the palatal flap, which we deepithelialize and which we're going to use as a connective tissue graft for augmenting the phenotype on the buccal aspect of tooth number 13. So you see the elevation of a split thickness flap in the entirety of the surgical field. We do not want to expose the bone anymore since we have already placed our implants. So we simply expose the heads of our tissue level implants. We create a split thickness dissection with a deep and a superficial split thickness elevation. And we create, in a so-called VISTA approach, a split thickness bed on the buccal aspect of tooth number 13 for the placement of our small connective tissue graft, which is pedicled with the apically repositioned flap. So you see the removal of the cover screws and the placing of higher healing caps, and the stabilization of our apically repositioned flap on the buccal aspect of our two implants. You see the placement of the connective tissue graft inside the pouch, and you see the stabilization of the apically repositioned flap at the buccal aspect of the healing caps. This is the healing 2 weeks down the road and 6 weeks down the road, when we're finally ready to take an impression and to start delivering the provisional restoration. Here you start to see the soft tissue conditioning 1 year after the surgery, and once we remove the provisional restoration in order to take the impression for the delivery of the definitive prosthetic work, you see the reestablishment of a very favorable anatomical environment with adequate amount and adequate quality of peri-implant soft tissues. And 18 months after the delivery of the definitive crowns, you see the final result with a little bit of also hypergrowth of the keratinized tissue on the buccal aspect of implant number 14. And here we can see some very nice histologic material provided by Professor Claudio Della Via and Dr. Gaia Pellegrini from the University of Milan, where both at the mesial and distal tree fine samples, we can identify a very satisfactory bone quality, considering that the harvest has been performed only 6 months after the regenerative intervention, and then no autogenous bone has been used, especially if we take a look at the presence of abundant vascular component, which seems to confirm the biological properties of this product that have been described in preclinical models. And these findings have been confirmed in multiple clinical cases of bone augmentation procedures, both simultaneous and before implant placement. Here we see, for example, the treatment of a buccal dehiscence to this implant number 35, which I treated with the simple application of RegenFast with the layered approach, combined with pure Bio-Oss without autogenous bone, and a BioGuide membrane stabilized both with buccal and lingual pins. And you see at the re-entry procedure 6 months down the road, a very satisfactory amount of bone gain, but most of all, a bone quality, which I like very much, with a very vascularized bone, which typically I used to see with the application of abundant amount of autogenous bone. And of course, the layers approach can also be applied with the use of non-resorbable membranes, but with a slight modification. Since it cannot directly target the osteoprogenitor cells of the periosteum due to the presence of the cell-occlusive membrane, what I typically do is harvest a minimal amount of autogenous bone, scraping the receiving site, and apply this minimal amount of autogenous bone on the outer aspect of the regenerative site, combined with RegenFast, right below the non-resorbable membrane. In such a way, we try to compensate the absence of the periosteal activity in the regeneration process by creating a secondary osteogenic site at the most challenging part of the regenerative site, which is, of course, the top of the vertical defect. And here we can see some nice material, once again, from Professor Delavie and Dr. Gaia Pellegrini, which shows very good quality of regenerated bone, and most of all, which shows the direct apposition of new bone on the regenerative site. But of course, aside from pure bone augmentation procedures, there are a number of regenerative scenarios where we wanted to test this technology. And in my mind, a particularly fascinating one was the regenerative treatment of peri-implantitis defects. And here, for example, you see the very first case of peri-implantitis that I treated with RegionFast. This was an implant in position 1.4, which was placed less than 1 year before my first visit. And you see how, after the delivery of non-surgical therapy and the removal of the prosthetic superstructure, I performed a regenerative intervention with a palatal papilla preservation incision, the elevation of a full thickness flap with the degranulation of the defect and the decontamination of the implant surface, and once again, the delivery of RegionFast in a layers approach. A first layer in the regenerative site, in direct contact with the bone defect, the application of Bio-Oss collagen as a reconstructive strategy, the second layer of RegionFast apply on top of the Bio-Oss collagen underneath a connective tissue graft, and finally, a slight coronal advancement of the flap and the watertight first intention closure of the wound around the implant-supported abutment. Here you see the evolution of the case after 6 months with very favorable clinical and radiographic findings, which led us to the delivery of a new prosthetic rehabilitation, where multi-unit abutments were used to correct the slight malposition on implant number 14, and to deliver a more cleansable prosthetic rehabilitation, where you see the final follow-up 1 year after the rehabilitation with very stable clinical and radiographic findings. And of course, another very fascinating environment to test this technology in my mind was the regenerative treatment of periodontal intrabony defect. So let me show you the very first case that I treated using RegionFast in this specific context, which was the case of 2 intrabony defects, one at the distal aspect of tooth number 12 and one at the distal aspect of tooth number 14. The surgical technique in this case was a minimally invasive surgical technique. So according to the modified MIST approach, we are just raising 2 very small buccal flaps with split thickness papillae and minimal full thickness elevation of the buccal flap. In the specific case of tooth number 12, I inverted a little bit the angulation of the incision to improve my capacity to see the palatal component of the defect from the buccal aspect of the surgical field without the need to elevate a palatal papilla. And at the distal aspect of tooth number 14, we elevate again a simplified papilla preservation technique in order to address the defect affecting this tooth. So you see a very, very limited amount of full thickness elevation. The papilla mesial to 14 was elevated simply to facilitate flap retraction. And once we have elevated both the papilla, the distal aspect of tooth number 14, and at the distal aspect of tooth number 12, we start the sharp degranulation of the defect in the intrabony component to completely eliminate the granulation tissue of the defect and to visualize the root surface facing the intrabony defect. Of course, we perform the granulation and the debridement of the defect itself. We remove biofilm adherent to the root surface with a combination of ultrasonic, sonic, and manual instruments, and we proceed to the same identical procedure at the distal aspect of tooth number 12. And of course, you can start to see that the 2 defects have very different configurations. At the distal aspect of tooth number 12, we have a very contentative defect, quite deep and very narrow, which extends up to the palatal, mid-palatal component of the root. And this, of course, is a defect that we can treat just with the use of biological booster because it has a very high capacity to maintain a stable blood clot after the surgery. While at the distal aspect of tooth number 14, the defect is less deep, it's wider, it's much less contentative, and it is for these reasons that I chose to perform a combination strategy combining RegionFast with the support, the mechanical support of Bio-Oss collagen. So after the application of ADTA on the root surface, in order to further improve the debridement of the root surface and the removal of the smear layer, you see the direct application of RegenFast, in this case in a single layer, because of course there is no bone graft at the distal aspect of tooth number 12, and then the closure of this papilla. While at the distal aspect of tooth number 14, you see a double application. A very first application on the receiving side, so inside the defect, and a second application after the placement of our bone replacement graft. So you see the very first application of RegenFast in direct contact with the bone surface and in direct contact with the root surface, the placement of Bio-Oss collagen inside the defect in a very minimal amount. We do not want to overbuild the defect in this case because we don't want to invade the space of the supracrestal soft tissues with our bone replacement graft, and a second layer, exactly as we were doing in the bone augmentation procedures, on top of the reconstructed sides. Of course, both in the mesial and in the distal defect, once we perform the primary intention wound closure, in this case with the conventional Laurel Gottlow sutures, we apply a final layer of RegenFast on top of the incision line in order to promote soft tissue healing. And here you can see the result 1 year down the road, where we can see the resolution of the pockets and where we can see, especially at the distal aspect of tooth number 14, a nice reossification of the defect combined with the resolution of the pocket. And this is the time frame in which we are ready to finally desplint tooth number 14 and to rehabilitate the tooth with a definitive prosthetic rehabilitation with, of course, a simple crown. And you see, of course, in the movie, the complete resolution of the pocket with the absence of bleeding on probing and the absence of residual probing, both at the distal aspect of 14 and at the distal aspect of tooth number 12. And of course, starting from the promising results in these fairly conventional intrabony defects, I was also curious to test the effectiveness of this technology, even in more challenging scenarios. And here we see, for example, a very severe endoperiodontal lesion. This is a grade 3 endoperiodontal lesion affecting tooth number 37, with both a deep distal and buccal pocket, which we treated, of course, first with an endodontic therapy and 3 months afterwards with a regenerative intervention. And I believe that these challenging scenarios are probably the ones where we need the most a biological stimulator as RegenFast, because in such challenging cases, everything that we have, which can help to improve the healing process, comes for sure in handy. So here you see the elevation of a bigger flap. Of course, we cannot deliver a minimally invasive surgical approach when we're treating more challenging defects. We need an optimal visualization of the defect in order to perform a proper degranulation of the intrabony defect and in order to perform a proper removal of the subgingival biofilm from the root surface inside the intrabony defect. Here, of course, the use of a surgical microscope is almost indispensable to provide an optimal visualization of the intrabony defect and to allow us to properly see the root surface during biofilm removal. You see that I'm aggressively removing all the granulation tissue and the biofilm from the root surface, and once I have completely finalized the degranulation of the root surface, which can take a very abundant amount of time, we are ready for the regenerative intervention. So you see once again that we dedicate a lot of time to the degranulation of the defect. We dedicate a lot of time to checking once and once again that the root surface is perfectly instrumented. We apply once again EDTA 24% on the root surface to remove the smear layer, and we are ready for the application of RegenFast once again in a layers approach. So you see the application of the very first layer, both on top of the root surface and on top of the bony walls of the defect. We are then filling the defect with Bio-Oss collagen in order to reconstruct the intrabony component. Of course, we have a very contentive defect, but we have a very wide defect, both mesiodistally and buccolingually. So we need a bone replacement graft to avoid the collapse of the soft tissue inside the defect. And once we have applied our bone replacement graft, we are ready for the application of our membrane, which once again, it's intended to stabilize the graft inside the defect, but most of all, to reduce the risk of soft tissue invagination inside the defect in the buccolingual component. So you see the stabilization of the membrane, and you see the application of the second layer of RegenFast on top of the membrane, which of course is going to stimulate both the periosteum and the periodontal ligament cells in the surrounding area. So you see the application of the second layer. And once again, exactly as we have performed in the previous surgical interventions, you see the watertight first intention wound closure, which is followed by the application of the third layer. It is very important to check once and once again that no blood is coming out of the sulcus at the end of the surgery to make sure that true watertight first intention wound closure has been achieved. And you see 2 weeks down the road, the maintenance of the primary intention at the level of the papilla incision. And you can see, of course, that the tooth has been rigidly splinted in order to avoid any tooth hypermobility. And 1 year down the road, you see that we can finally check the absence of residual pockets. And this is one of the most satisfactory moments for me, of course, because it's the time where you see the resolution of the pocket and you can finally remove the splint, and you can finally check that the tooth has no residual hypermobility. So you see the removal of the splint, you see the complete disappearance of the tooth hypermobility. You see, once again, after the removal of the splint, that when we perform probing around our tooth, there are no residual pockets and there is no residual bleeding on probing. So the patient is finally ready to receive a simple ceramic overlay on top of the occlusal reduction that we had performed at the end of the surgery in order to establish a functional occlusal surface. So hitting to the end of the presentation, these are the very first lessons that I've learned while testing this novel material. I can say for sure that RegenFast is a very easy to use material, which most importantly does not increase my surgical times, and I could not see a single adverse reaction with its application in a surgical environment. Hard tissue healing seems to be faster based both on clinical feeling, radiographic finding, and some limited histomorphometrical material. But most importantly, remember that a sound biological strategy has to be applied to optimize results. So my suggestion is to use it in a layers approach with small amounts applied in multiple applications. But of course, before saying goodbye, please bear in mind that these findings are just the result of very few anecdotal case series, and that there is a very long yet very exciting journey ahead of us where we have to validate this material both at the preclinical and clinical level with sound, randomized experimental environments. So I would like to thank you very much for your kind attention. It has been a great pleasure to share these moments with you. And of course, we are ready for the Q&A session where we can share some thoughts together. Thank you very much once again.